Good evening and welcome to tonight's presentation, Managing Vulvovaginal Candidiasis. My name is Elizabeth Farrell. I'm a gynaecologist, medical director and one of the founding members of the GeneHales. Firstly, I would like to start by acknowledging the traditional custodians of the land we're presenting on and the lands we're reaching tonight. I'm in Melbourne, on the land of the Wurundjeri and Boonwurrung peoples of the Kulin Nation. I recognise their continuing connections to land, water and culture and pay respects to elders past, present and emerging, and to all Aboriginal and Torres Strait Islander peoples who may be with us tonight. For those of you who don't know the GeneHales for Women's Health, we were established in 1992 with a vision to provide practical, accessible and expert health information for all Australian women and girls. In tandem with our consumer education, the organisation also develops educational resources for health professionals, including our webinar series, tools and online e-learning courses. Tonight's webinar is recorded and we will advise you when it is ready to view on our GeneHales website. You can find a link to the presentation slides in the Resources tab at the top right of your screen. Please take a moment to download them now. We thank you for sending in your questions, and if time, we will aim to answer them at the end of the webinar. You can also submit questions via the Q&A tab at the top right of your screen. If you require a certificate or RACGP points, you will need to complete the evaluation questionnaire. This will come up as a link on the screen at the end of the webinar. I would now like to present Dr. Tanja Bohl, who is joining me this evening. Tanja is a dermatologist who works at our GeneHales Medical Centre in Clayton here in Victoria, where she is the head of our specialist vulval clinic. She also works in private practice in Gippsland in Victoria. And we're all about to head off to Dublin for the International Society of the Vulvovaginal Disorder Society. I've got it all wrong there.
It doesn't matter.
But Tanja is our president-elect of that society, so we congratulate her on going to achieve the role of president later this month. The aims of tonight are to recognise the varied clinical presentations of vulvovaginal candidiasis, to identify common points on history that suggest diagnosis, to appropriately take specimens for microbiological evaluation, institute therapy, and plan further investigations if necessary. Please note that this presentation contains multiple images of vulval conditions for the purpose of upskilling clinicians in the recognition of these conditions. Now I'll hand over to Tanja to give tonight's presentation. Welcome, Tanja.
Thank you, Liz. I would just like to add my thanks to the ladies who have given permission in writing for their clinical photographs to be de-identified and used in such educational programs. Without them, this would be an extremely dry and not nearly as good an educative process. So often when a patient comes to you with candida, there are certain common questions that they will ask you, regardless of whether they're presenting for the first time in their life or whether this has been something they have been struggling with for a long time. And it really doesn't matter how often we hear this. We need to develop a way of dealing with these questions when they come up and be comfortable that we can answer them without being dismissive of the patient, because we might be hearing it for the 100th time that week, but she's sitting in front of you and she's saying it for the first time. And the sorts of questions that you can see there, like, why me, why now? Unfortunately, incredibly common, and we don't have a satisfactory answer for most women in that situation. And all the other questions that are there often come up. And as I go through tonight's presentation, I hope that we will cover most of those individual questions and points, and that in reviewing the slides, you'll be able to incorporate them into your clinical work. So everything starts with the consultation, and our most useful aids when it comes to making a diagnosis and evaluating our patient are actually our ears, our eyes, and the brain that connects those two and puts things into context for the individual patient in front of us. And really, although that has got a lot of text on it, it's no different to examining a patient for any other medical reason that they might come to you. You have to evaluate their symptoms. That will give you perhaps a bit of a clue of where you're heading. Anything that the patient has noted herself, it's important that you acknowledge that and vindicate her observation, even if you yourself think that that may not be important. Menstrual and objective history can teach us a lot, as can what medications is she taking, the predisposing factors, and so on down that slide. They are all things that give us context that may help us to be able to answer her questions about why me and why now. And I find if you have the time, and one of the great luxuries that we are able to have at Jean Hale's Vulval Clinic is that we can allocate more time to patients on the first visit, is that we can say, is there anything else to the patient? And that way, hopefully, they'll open up about anything more that is worrying them, or possibly even something completely different they want to get off their chest, so to speak. So the factors that we do find commonly are listed there, and that is true regardless of the type of candida that is present and regardless of whether it's first off acute, recurrent, or chronic candidiasis situation that we're dealing with. Often repeated antibiotics, and it's not just the wisdom teeth extraction or chest infections, which have been particularly common in the last few years. There's also things such as acne therapy. And whilst it is important that we manage acne effectively as a dermatologist, I think I speak for all dermatologists, we are very acutely aware that we're giving an otherwise potentially really healthy young woman contraception and antibiotics, and then possibly adding to that isotretinoin, all of which will affect her mucous membranes, the propensity, to develop candidiasis and also to develop eczema. One of the common scenarios that we see is women who ring in or who come in and say, my lichen sclerosis is no better than it was a month ago, or my lichen sclerosis is flaring and it doesn't matter how much cortisone I put on it, it just gets worse. And so often in that situation, they've got a superinfection with candidiasis. Cyclical symptoms, particularly in the week before menstruation starts, should be called cyclical vulvitis. And by far the most common cause of this is actually candida, which for various reasons, just including things such as the change in the immune system function prior to a menstrual cycle starting, which is in fact affected by the hormones changes that occur at that time, make it great for thrush or candida to thrive. Vaginal dryness will be present in most women who have recurrences and those who have chronic candida. There, what we're seeing is a response of the skin of the vulva and vagina to chronic irritation. So the typical beefy, red, swollen, wet vagina with copious discharge that every woman associates with candidiasis is often not present. They may simply complain of dyspareunia, and particularly splitting and burning after intercourse. Sometimes there may also be swelling, and you need to include chronic candidiasis or undiagnosed candidiasis in one of your potential risk factors for the cause of dyspareunia. The examination technique, I believe you will all be familiar with. The important thing is that unlike perhaps taking cytology specimens as we are all accustomed to, before you actually get that close to the patient, you should be looking at the entire vulva, the inguinal creases, and you need to then look at before redness, swelling, spots, erosions, ulcers, splits, or satellite lesions, which I have some good photographs and will show you exactly what I mean in a few slides. One of the things that we've also been taught in the past, Liz, is that we should be taking high vaginal swabs.
Mm-hmm.
And what we have found when we've done high vaginal, low vaginal and vulval swabs is that, in fact, you can get a mixture of candida species. And interestingly enough, the high vaginal swab can be low or negative with the presence of candida on the vulva.
Mm-hmm.
So at the clinic, we generally take a low vaginal swab that embraces the vaginal introitus and vestibule. And if there's a lot of discharge and we think it may extend beyond that, or if there is splitting, then we will take an additional specimen from the vulva for that reason. So something to consider when you're actually taking your specimens. Usually if there's enough discharge available, we try and get it on the swab, get a clean glass slide and smear the discharge onto that before we put it back into the medium. Now, we use specimen collecting swabs that enable us to do that. There is a great move to PCR diagnostics at the moment, and that's not something that you can do in that setting.
So really, every woman that comes with a vulval itch or vulval symptoms should be examined and the labia parted to look for any of the symptoms and signs that you've already mentioned. It's not good enough when a woman comes in and says, I think I've got thrush, for the health professional to prescribe something, is it?
No, not at all. And that really, I think we're sufficiently long in the tooth to say that we were taught that more mistakes are made by not looking than by not knowing. That really invites, and unfortunately when you do this more and more often, you will experience that sometimes you will miss a cancer, or you will miss an ulcer, or you will miss lichen sclerosis. And when, in particular, one lady always springs to mind because she was a delightful patient who would come in and she was 96 and she said, "Oh, this damn thrush, I can't get rid of it." And I would see her for a dermatosis that was associated with glucose intolerance and celiac disease. And I just was thinking immediately, I don't think this lovely little 96-year-old lady has actually got thrush at all. She wasn't on any form of local or systemic hormonal therapy. And sure enough, she had very florid lichen sclerosis. And after an 18-month battle of seeing her local doctor, who would give her different prescriptions, including on one occasion some topical steroids, but felt uncomfortable examining, the diagnosis was missed and the treatment was ineffective, unfortunately. I'd like to say that this doesn't happen anymore. I would have to say that some people are excellent and for some people have legitimate reasons why they don't. But I think if that's the case, you shouldn't prescribe.
Excellent.
So now I'm just going to talk about the different types of clinical presentations of vulval candidiasis, as well as those that are due to Candida albicans and non-albicans organisms. And this is what we know from our medical school, hopefully. The acute or typical candida, as I mentioned briefly before, is very common, and it's been estimated that it occurs in about 75% of women at some time in their life. And I reached the point now where I think every woman expects that every itch is thrush or candida. And often by the time they've gone to their healthcare professional, they will have tried various things with variable effect, because even if the diagnosis is one of candida, some treatments may not be sufficient for her. And if it isn't, just applying an ointment of some sort may benefit other conditions. And typically we expect to see candida in the 15 to 55 or reproductive years of age. Young girls before puberty don't get candida unless there's something wrong. If they've got florid candidiasis and they're a young child or an infant, you have to think of some of the congenital mucosal deficiencies that can give rise to that. If they're young girls going to primary school, you have to think of eczema, which is the commonest reason for them being itchy, not candida. And you will find that if you do come to look at these women in the typical age group, in the typical setting, with the caveat that postmenopausal women may well be applying local hormone or on systemic therapy, which changes them back into this most at-risk group of women, that there will be typically sudden onset of itch out of the blue, swelling, the profuse discharge, and this thick, and they often describe it as musty odour. In these women, a swab is still important, and it will often show lots of organisms, whereas in some of the more chronic cases, which I'll discuss shortly, that may not be the case.
So when you talk about lots of yeast on the swab, you're talking about when the pathologist looks or microbiologist looks at it under the microscope. But we talk often about cottage cheese appearance.
Yes.
Is that also an appropriate term to use?
Well, as somebody who eats a lot of cottage cheese, I'd have to say no, it can be off-putting in certain settings. I think that a lot of discharge that we were once thinking or used that description for, you just don't see that a lot clinically. What you will usually see is copious amounts of white discharge, and if you try to rub it with the swab, it tends to show that there's an inflammatory base beneath, and it's described typically as being hard to shift, whereas normal secretions come off quite easily with the swab. Yeah. Okay. And the important thing to stress again in these women is please use the entire course of treatment, whatever it is, completely, as you should with your antibiotics, because failure to complete that or stop when you feel good may not give you a long-term enough response. So we then talk about an acute recurrent, and that's when they've got a variation of what we've just discussed, but they get it often. And sometimes it can be so often that there doesn't appear to be any normal vulval time at all in their lives. Some will say, even if that's the case, they might say, oh, it started off being worse just before my period, and now it's just all the time, and it doesn't matter when my period comes or doesn't. And so in this sort of situation, you need to be aware that, yes, if this can indeed be candida, but this is not going to respond to the same short course of therapy that one episode of acute candida may. It's going to require an initial course of therapy to get everything under control, and then long-term suppression in order to allow the tissues to return to normal, hopefully the immune response to improve so that you can then withdraw the treatment. And this is the sort of thing that I'm talking about. On your left, does this work?
I'm not sure, try it.
Okay, so we'll look. You don't want me to use this? Okay. So on the left, you'll see the area that I've marked at redness, and really one of the first things that strikes you with all of these clinical photographs is that there's a lot more red around than there should be. And you can see also, if you look at the inguinal folds here, that there are what we call satellite lesions. And really what that means is, if you're thinking about the sort of satellites we have now, the vulval vestibule is earth, and all the things that circle the earth are satellites. And it's quite a common feature of candida, and something that if you see it, you should be thinking candida indeed. And often if you look very closely, what you will see on these individual lesions is just this tiny little circle of scale on top. And it's quite reasonable to take specimens from both. Psoriasis tends not to give you this severe red inflamed vulvitis with the satellite lesions. You can actually get lesions in the inguinal crease and the vulva can be completely normal. And when you look there, you can see how much discharge there is. Now that's white. It's difficult to remove. The base of the vestibule is extremely inflamed, and what you can see of the vaginal introitus does show that there's further discharge higher up. And if you don't look for these things, they can be relatively easy to miss, particularly if you're just going to go straight in and take a swab from the vestibule.
Are you recommending that every patient who comes in with the potential of thrush to have a swab?
Ideally, yes.
Ideally, yes.
Yep.
And what about your physical examination if somebody's already previously gone to the chemist and taken some antifungals from the chemist?
I think that's when it's even more important to really look, because the culture may be negative depending on how recently that happened. So if you then in that situation think, well, yes, you have treated yourself, but I can still see features of candidiasis when I examine you, then I think you should still take the swab, but start treatment based on your clinical evaluation. And this is another example, and you'll see both of these ladies have underlying lichen sclerosis, a bit more obvious in this particular example. But you've got some really good satellite lesions. You've got visible anatomical change. And you also have on the image to your right that shows the perineum, the white changes that in this case are due to lichen sclerosis and not an adherent discharge. So just as STDs travel in company, so too does candida. It's just because you've got lichen sclerosis, it doesn't mean that that's going to be responsible for every symptom that you have from there on in. And this is a lady who we saw earlier this year in clinic, and she'd been seen twice before and her steroids altered. And then she came to see me and she was no better. And so I just went through the whole thing again from the beginning. And this is the advantage of being able to go in and see patients that other people are seeing, is that you get another perspective and you can speak to a colleague. And she had lichen sclerosis, but what you can see here is all that white that's in the vagina and that's in the vestibule is in fact severe candidiasis. There is some lichen sclerosis present, but even that warty appearance on the patient's right inner labium is in actual fact due to candida and chronic scratching and resolved with treatment. And this is one of those situations where the steroid that you're applying to treat one condition may well give you a little bit of relief from the itch temporarily, but it does help the infection to go deeper into the tissue, then be more resistant to therapy. And particularly, you need to consider that in many of these ladies, they also have concurrent vulvovaginal atrophy. So we might therapeutically add a topical corticosteroid, which has to be of a reasonable potency or it'll do nothing. And then we're adding local estrogens. And we're really setting them up for candida.
And do you think sometimes the candida also comes because they use excessive amounts of the steroid, or do you think it's just because you've got that combination there at greater risk?
No, I think it's both. I don't know how important each one is, but if you can imagine using 15 to 30 grams of a topical corticosteroid in the matter of a month, that tells you this
seems a lot.
It is. That's ordinarily when you're on maintenance therapy for lichen sclerosis. 30 grams should give you twice a week treatment for a year. So it's worth keeping that in your back
smear, just a smear.
It's the thinnest of smears. So in that situation, yes, far too much is going on. And on non-lichen sclerosis affected skin, which you will often get to, it does actually affect the local tissue response and will make them more prone to it.
Okay.
And then we come to the last one, and I think probably, pardon me, the category of Candida albicans infection that we see the most now. And this is the chronic candidiasis. And I think part of the reason may be because of partial therapy, concurrent antibiotics, concurrent ill health for other reasons that has not been looked into, as well as what we will be using topically. And in this situation, as before, the itch is continuous. But when you have a look, what you see is one really rough, skinned vulva with a lot of hyperkeratome present, which just gives you that grey overlook when you look clinically. The skin markings become exaggerated, and it would look like lichen simplex that you would see on an arm or an elbow or anywhere else on the body, but not something that you expect to see on a mucous membrane. In this setting, the changes can be so severe that you may not be able to find any candida on the swab because there is not much of it, we believe, then that you may in fact be eliciting an acute eczema and that becomes chronic in some of these women. But the other thing is that it's been going on for so long that it becomes deeper, and all the inflammation that it triggers is responsible for the other features. And those that do come to biopsy show a chronic spongiotic dermatitis with a mixed infiltrate. Now, most laboratories now do routinely do a PAS stain for candida. I think if you have a look for that and it's negative, it shouldn't put you off the diagnosis. But that histological picture, which is, people look at it and think, well, what's the point in doing a biopsy if you get this back all the time? It's telling you there's inflammation there for some reason. And you need to then consider, what are they putting on there? How are they cleaning their vulva? And what else could be there, of which candida is certainly likely to be. And these are less inflamed ladies when you look at their vulva than previously. But what you see is that you do see swelling in the vestibule in the patient on the left, but these quite dreadful splits that are quite elevated, and the tissue looks quite boggy and swollen. And what's happened here is that there has been dyspareunia and splitting with intercourse, and that in fact prompted the visit to the clinic. But when you have a look, it doesn't look like the acute candida that we were talking about before, but you can see clearly splitting is happening and everything's inflamed. Now, if you biopsy that, you will probably find some candida present. But then if you take a swab and either stop everything, review her cleaning routine, review what she's tried to put on herself, and just institute something really bland like a liquid and soft paraffin mixture, and you wait a few days to a week for the results, things will often dramatically improve and you'll get a positive result and you can then treat. Although, if you are very suspicious that this is candida, there is absolutely no reason, I think, why you couldn't start treatment at the initial consultation. And these are the ladies in which I tend to first off use oral therapy. Not that topical won't be effective, but I think if I had, you just think, what would I do myself in that situation? You're going to ask her to use sitz baths. Potentially you're going to ask her to put on a bland emollient. So then adding yet another thing to do to the vulva, it can be just traumatizing.
So one of the things that we usually would say in the vulva clinic is to adhere to vulval care.
Yeah.
And Jean House has a vulval booklet that you can look at online, and in there is a page on vulval care. So no soap, cotton undies, making sure that women are not wearing lycra, things like that. If they're wearing panty liners or pads or tampons with their periods, that they have 100% cotton. So have a look at the book and you'll find out what we always tell each patient about vulval care. And there are 3 ways of reducing irritation, either with a cold pack, with a sitz bath. I like bicarb, you like salt.
I know. I like salt because I can say, if it stings, you've used too much. And that's the prime reason, because it gives them an actual indicator. Otherwise, they think if a little bit's good, more might be better.
And the third thing is to have a spray bottle by the toilet and every time with a little bit of salt or bicarb.
Doesn't matter, they're both effective.
In with it, and every time the woman voids or opens her bowels, that she sprays her vulva and pats dry and gets the urine off so that it's not going to irritate. And that's when she can put that barrier cream on while she's waiting for treatment.
And sometimes if they're this severe, it might even be useful to put either a bit of bicarb or urine into a glass of water for a few days just to make the urine less acidic and stimulus.
Oh, excellent.
So
okay.
And they're very similar to the biopsy care guidelines we give. Yeah, exactly. So on the patient on the right, what you can see, again, inflamed tissue. It's not bright red. It's got this dull red, not quite right look about it. And there's this great long split in the interlabial sulcus, which would be really easy to miss if you didn't, as we discussed earlier, part the labia and have a look for all these anatomical features that should be there, and then you'll see it. And sometimes it might be so difficult to see what the patient's actually most concerned about or where the splits are. Just give them a cotton bud and ask them to show you. That's quite an educational process in itself. Okay, so this is what chronic vulval candidiasis looks like. And you can see here, yes, things are red, but they're not that bright red that they were. On the left-hand side of your screen, things look dull, rough, coarse, and there's a lot of wrinkling going on there. And this is a woman who has quite florid long-term pruritus or itch, and she's long-term scratching, and nothing she puts on gives her relief. And that looks like a chronically eczematized vulva. But if you take the swabs and scrapings, which you should, it doesn't mean that there isn't eczema underlying it. The question here is it candida that's produced lichen simplex chronicus changes, or lichen simplex chronicus that's contaminated now with a candida superinfection?
You've used a word that you haven't used before, and that's scraping.
Yes.
When would you use a scraping of the skin rather than a swab?
If you're comfortable using a scraping, you can imagine that in that lady on the far left, you're really not looking at any surface that's moist that is going to give you organisms on a dry swab. And that's the setting in which, particularly if you have help, but if you don't have help and you pull the tissues apart, just on her lower right-hand side, just taking a gentle scraping of that roughened skin is often very beneficial.
And is that then done dry under the microscope?
Exactly.
You don't put it in any container or any medium?
No, you don't put it in medium. You put it in a sterile urine container, and the microbiologist at pathology will look at that, and then they'll culture it.
So the middle one has got satellite lesions.
Yes, but also she has got quite a lot of satellite lesions. That entire mucosal surface looks as though she's got superficial little tiny erosions, which she does have, and it would be easy to think on first glance that that's going to come back as herpetic. But what we'll say, no, it isn't, is how long it's been going on. And you don't have it going on and on and on and on and not resolving. So, yes, when you part the labia even further, what you notice is that there are these acute erosions in addition to the chronic eczematous change, virtually no discharge. So in that setting, not at all a typical acute candida presentation, but please take the swabs. And it's quite reasonable to take swabs for herpes PCR in this setting, but you should be doing both. And then in the final example, and this is all the one patient as we go across, but looking further and further into the tissues towards the anus and towards the vaginal introitus, that's where you can see more crusting and splitting, and it looks almost as though it could be a bacterial infection.
So what you're saying is this is an absolute example of parting the labia,
yes,
and finding a slightly different picture each time as you pull the labia apart.
Yeah.
And
it evolves. Yes.
Which evolves, yes. So what's the pathology, what's the histology look like?
If you were to take a histology, it would depend slightly on which site you took it from.
Right.
So if we start on the far left, you will get that typical chronic.
So have you got
eczema.
a picture of it? Have you got the next slide?
I have got, yes, and it would look like this, but as you went further in, the upper layer where the keratin is, in the first example on the left, the first slide of that lady, that would be even thicker because all that grey tissue is keratin that is there. You can see the long reety ridges, and they would be longest where the skin tissue is still stratified squamous epithelium. You don't see any erosions there, but if you can imagine if that top weavy keratin was removed and you had a little divot underneath that keratin, that would be the erosions you're talking about. The acanthosis is there, and the crusting would be more evident in the final slide.
Okay, so what you've got another slide showing
I do,
candida.
and this is a close-up of the previous image, and what it's showing you, this is a PAS stain, and this shows you where the organisms are, and this entire keratin layer is just riddled with little yeasts and what we call budding pseudohyphae, and that tells us it's likely to be candida, although we always would wait for the culture.
So moving on.
Yes.
To
So when we talk about why people get it, I think that the short answer is we're not sure, but as we do things like give life-threatening candida septic infections to people on some of the anti-interleukin medication, that's when we find that there might in fact be the epigenetic and genetic findings that are there. Localised hypersensitivity, you ask a question if somebody has asthma, eczema or hay fever, and history is there. And if the person, some things we can change, as you mentioned earlier, and some we can't. Hormonal factors, I think we've alluded to quite a lot. And so we can leave the albicans candida and move on to the non-albicans candida, which is becoming a bit more of a nightmare.
Why is that?
We suspect that it's because we're having a lot more treatment out there with the fluconazole that just knock off the
So
albicans.
you can go to the chemist and the woman can go to the chemist and get the thrush treatment and oral and
local,
topical.
Yes.
And so then you're...
So what you're then seeing is a very altered microbiome in somebody who's predisposed to a candida infection. And it was a concern of microbiologists that this would happen, in similar to antibiotic resistance, etc. And unfortunately it has. Bigger problem in the United States than it is here, but still an issue.
So tell us a bit about these non-albicans candida that you've mentioned here.
Well, I think, first of all, they don't usually cause as much inflammation as albicans can. So even more, we need to have the little prickling at the back of our neck that says swab if something's chronically irritated or chronically itchy. And chronic dull irritation is perhaps more prevalent than itch.
So do we have to ask the laboratory to specify the candida, or will they just say, oh, well, it's non-albicans?
If you don't ask for anything, they'll say it's non-albicans. And what you'll tend to do, if you say, please subspeciate if positive, that's great, but not every lab can do that. As we turn to PCR for our candida diagnosis, there's nothing left to subspeciate on.
Okay.
So that's something that, as this becomes a bigger issue, if it does in fact do that, we will need to look into further. So you need to think about the fact that also these organisms tend to be less affected or less eradicated or subdued by the usual medications that we have. So there's really not a lot of point in belabouring the oral azoles in this setting. Those different measures that are up there in the nystatin compared with the two different azoles have been shown to be equally as effective, which is not terribly effective at all in this setting. And this is where we tend to look for biological cure with something like boric acid.
So let's move on to management, because that's what everybody wants to know.
Indeed. So I think, again, we need to make sure that we remove absolutely everything that could be contributing to this lady being predisposed to getting candida. Secondly, we need to think, is there something in her general health that might be doing that we're not considering? And in this setting now, I'm finding more and more women who are on biologics for bowel disease, etc., because they're becoming more available. That group will become a bigger group in the future. And I find it always useful to write things down for people because they don't tend to remember everything you tell them, which is fine.
So how do low iron stores impact on one's risk of candida?
We're not really sure. There was a time when being anemic and having low iron stores was thought to be related to candida risk. Then we went through it, no, it isn't. And then there was a Swedish study that revisited it and said, well, actually, yes, it is. Mm-hmm. And I think we're seeing more people choosing a lifestyle that excludes meat. And it's often in a younger age group where they're menstruating, so that there are many reasons for them creeping into a low iron state. And if it's there and we give them supplements and enable them to be globally healthy, then it would be a logical thing to do, even if it's not specifically.
And when you talk about communicating clearly, what you're meaning is making a plan for the patient, yes, and giving them a copy and making sure you tell them all about whatever your plan is in terms of, and staying optimistic. That sounds very good.
Well, so, because you and I will go, oh, it's another globrata. What are we going to do in this person? But yes, you don't want to be saying that in front of them. They'll feel that anyway.
So let's move on to acute candidiasis. Mm-hmm.
It really doesn't matter which of those therapies you would use for a single case of the acute candidiasis that we talked about in the beginning. What is important is that the complete course is used for maximum benefit, and that fluconazole yes, it's designed to be a one-dose wonder, and it often is, but it often also may not be enough. And if you have an impression there's a lot of tissue reaction, it's perfectly reasonable to give a second or third dose in that setting.
Okay.
It's much more common to do that if you've got recurrent acute, which really we don't have a good definition of, but I think that's, no.
Does it matter which one of those previous azoles you would start with, or no?
No.
Okay,
no. The azoles are more effective than nystatin. Amphotericin locally is more effective than nystatin, but if the azoles will often irritate, and if you've got a very irritated vulva, it might be a reason to not go down that path.
Okay. Now you've used a term here, recurrent acute, as equivalent to chronic candidiasis. Yet we've been talking about them almost as two separate disorders.
I think that we can look at them as two separate things, but in reality we don't have a good definition for either, and they're managed virtually identically. So I think it becomes the time when you can say they're equivalent for a management perspective.
Okay, so we're talking about chronic candidiasis as being a number of conditions per year.
Yep.
And
I think generally people will say more than 4.
Okay.
And if you have more than 4, or if you have that continuous symptomatology where there's no break and the vulva never feels normal, it all falls into that.
And do we rely on the woman saying, I've got thrush again, or do we swab?
Always swab.
Okay. So chronic candidiasis. So when we're treating recurrent acute candidiasis, which I think is your slide before.
Whoops, let me just go back there.
One before that, yes. Mm-hmm. So you're talking about suppression for 6 months.
Yes, and this data is old, but it is a randomised controlled trial, and we really don't have good data.
So you can use vaginal or oral, or you use oral?
I think most women would prefer to use oral than a messy
for 6 months.
Benign statin. Yes.
So what dose would you use?
I prefer 50 milligrams a day of fluconazole, which seems to be sufficient for most women, because in that way I find that they just remember. Mm-hmm. And if you look at the blood levels, which require a certain amount of the fluconazole going in every over a 72-hour period, it works out equivalent.
Okay.
And I'm happy for them to do that. But sometimes when they start,
Yes.
I may indeed start them on a 150 milligram initial and then go from there.
Okay, we've only got about 14 minutes, so we've got to...
Well, we've got to get to some questions. So I think
so we
people
need to,
will have that slide,
yes,
which tells them what actually we mean by induction and suppression.
So what comes first?
I don't know
what
why.
do you mean by induction?
Well, by induction, you mean hitting them first of all to try and gain control of it, then recognising these women are very prone to candida, plus not all of our treatments are really fungicidal and can induce a absolute sustained microbiological cure.
So induction there, you've got the topical antifungal cream and pessary for 10 to 14 days,
yes.
and
yes.
fluconazole 50 milligrams. Underneath.
You can use
is that
either.
What it is?
Yeah, you can use either.
Yes.
Topical or oral.
Or oral. Okay.
And I haven't made that very clear. Thank you for pointing it out.
And the suppression, is that either or?
Yes.
Okay. All right. So there we have good.
And I'm sorry, that slide could be a lot clearer.
Okay, that's fine. We can sort that out. Okay, so next we've got when we review them.
Yes.
So after 4 to 6 weeks.
If they're very much affected with a lot of ancillary skin change, I might review them sooner, but 4 to 6 weeks is fine.
Okay.
Yeah.
All right. Okay. And you increase the dose if the culture is positive in these particular...
You reculture them at that point. And if they're continuing to grow candida, for example, if they're on 50 milligrams a day and we're still growing candida on a swab when we review them, they might feel symptomatically better, but we need to give them more.
Okay.
Doesn't happen very often, but it's important to know when it does.
And what else? What's the next? So here we are.
Okay. Resistance is something that often is asked about, and it's really extremely uncommon, but that's the time when you would perhaps cease the oral azole for a little while, take another specimen, have it subspeciated, and if you feel that if the swab is positive and they're taking it all correctly, then you can either up the dose initially, and if they respond, fantastic. If they don't, then change what you're using from an azole to a non-azole.
Would you ever use a single dose of clotrimazole 10% cream versus 3 to 6 days? That's, I assume, in the acute phase.
In the acute phase, I think you're asking for that lady to develop recurrences, and I don't for that reason. But I see very little number of women in that setting.
Okay.
So if there's no point in if you've got local azoles and they're not working effectively, oral azoles are not going to work that effectively. We only have fluconazole available to us. All the others are under very special circumstances at the moment.
So if the azoles are not working, we have to switch to something else.
And that's where vaginal treatments such as boric acid and amphotericin B come into play. They are messier, they may require longer term treatment, but they are local and they are also effective.
Okay.
I'll just say at that particular point, if initially there's a lot of inflammation, staying away from things that go into the vagina that may potentially irritate may mean that, okay, if you prefer to give something orally initially and then follow it with topical for suppression, that's okay, provided that it is actually working and the swab comes back as negative.
And they put the azole or the cream right up to the top of the vagina? As
far as they can reach. I mean, with the amphotericin lozenge, which is the usual way that we give it rather than compounding it, you need to dampen it first, because if there's not a lot of discharge, it won't dissolve necessarily, and then insert as far up the vagina as you can. And that becomes easy to go further on once inflammation settles.
And what's the long-term success rate?
Well, recurrence is high, 50%. And it doesn't matter really what you use, it's high. And we suspect that the reason for this are the host factors that we can't control. And each time you see a lady, if she's not getting better the way you anticipate that she will get better, you need to go over those general medical health questions, the hygiene questions and everything all over again to see if there's something that perhaps needs to be tweaked.
Okay.
And, you know, some women will go 6 to 12 months and then they'll be fantastic, and the minute they stop, it starts up again. And you will investigate them and you will end up in the same situation. At the moment, we really don't have a good plan for these women. And the success rates and the long-term treatment isn't really something that's looked at. Long-term treatment is 6 weeks for most studies.
So you're saying that really suppression needs to continue for another 6 to 12 months?
Yes.
Okay.
Yeah. It's reasonable after 6 months to give it a break. And then if you find they flare very quickly.
And not to use the fluconazole in pregnancy?
No, you can't use it in pregnancy. It's toxic to the fetal liver.
Okay.
Occasionally they might for severe nipple dermatitis and withdraw a breastfeed for 24 hours, but no.
Okay.
No. And even boric acid can be an issue sometimes.
Okay.
You need to do that in consultation with your obstetrician. And one of the nice things compared to when we used to use ketoconazole, you don't have to do regular monitoring liver function tests with the flu.
That's good.
Yep. And this is an example of a lady who just has a constant chronic problem with recurrences of swab positive non-albicans. And in this setting, it's easy to think, well, I think you've got to start and think, is it actually the albicans is it actually the candida, I beg your pardon, that is the issue? But we've investigated and biopsied, and that seems to be the only thing that grows and gives us an issue.
So can we look at treatment?
Yep. I think the important thing is that it's not evidence-based. We just don't have the evidence. This is what most people do and write about. And again, I would not, if you're going to use the fluconazole, you would have to start at 100 milligrams a day. And depending on the subspecies.
And that would be every day? Every day.
Subspecies which you may or may not know, given how it may not be possible to subspeciate, then it's certainly, I think, better to look at the local therapy with the amphotericin or with the nystatin.
Okay. All right. And what else can we use?
Really, that's about it at this point in time. Boric acid is the other thing, and that's the 600 milligram capsules, inserted 2 or 1. Now we're changing it to 1 every night for 14 days. And then what I tend to do in women with chronic issues is that I will just space out how long it is in between. For women with cyclic vulvitis, you can just insert 2.
I think you've got it on the next slide, have you?
I should have.
Oh, yeah, here it is.
There we are.
So 1 or 2 in a. So you have to get it made up, compounded.
You do. It needs to be compounded.
And the same for the amphotericin
lozenges? If you use, not for the lozenges, and that's the advantage of using a lozenge.
So the lozenges are already available?
Yes. And as you asked before, do you need to get the cream all the way into the vagina? You can't really do that with the lozenge. You need a 3% cream to do it, but then you have to have it compounded. So I'd start with the lozenge.
Fair enough.
And often you don't need to do anything else. Really need to pursue having the compounded cream made up, but it is an option.
And it's expensive, I assume.
Even the boric acid, they all work out at about $60 for 28 or $60 for a tube of 50 grams. So yes, they are. Okay,
so with non-candida, non-albicans candida, as we said, we're getting more of it. So we need to treat it, or we don't need to treat it. Do we only treat it if it's symptomatic?
Yes. As things stand at the moment, if the patient has got vulval symptoms and you assess that that is the reason for them, then you treat.
So you've got the in vitro testing. What does that mean?
It means that it's tested in the laboratory, not in the actual human being. And a lot of things that are in the literature at the moment that are being seized on by probiotic manufacturers a few in vitro tests that show that this might work under these very controlled circumstances. So then they go and put that in a probiotic and say this will work.
All right. So tell us about the key messages. What are the key messages for tonight?
The key messages, is that it doesn't really matter what you use. You're going to make most women better initially. The longer treatment is going to be required when there is a recurrence, or if at the very first time things are really, really severe. And in those, you know that you're in for a longer haul. You need to be mindful that if condoms are the contraception that your patient uses by choice, that all of the vaginal treatments that we've spoken about can weaken condoms. So you need to discuss that. At initial consult, they may say, it hurts so much, I'm never going to have sex again, but in fact they will. You can add a hydrocortisone ointment if there's a severe vulvitis. The reason that I say not to use a combination is because quite often they sting, and it's quite often the azole preparation. So if you have them separate, you can then use the two separately and perhaps add boric acid or increase the steroid if you need to. Okay? And there's no point in taking oral nystatin drops or amphotericin lozenges, as we've had this year. A lady referred to who was given amphotericin lozenges with no effect, and then we found out she was asked to swallow them. It just passes unaffected through the gut.
Okay, so that's where communication
is vital.
Clearly is very important. Yeah. Yes. So your final messages? And
I think keep it very, very simple. Despite the fact that we can do PCR, yes, that's important, and you've got to do what your clinic does, and we can't be pedantic about that. But really think candida and think it often, and swab often. I think that taking multiple swabs can tell you a lot about your patient over a period of time and make management easier. And it also helps you to appreciate what else is going on. Yep. I find an air-dried smear, and if you have a positive microscopy and you're seeing lots of budded yeast on it, it may be a part of the normal microbiome of that lady. But if you're seeing pseudohyphae, that is telling you that it's in a pathological state, and yes, it's causing problems. So that's the advantage of that.
So thank you very much. That was fabulous. But we're going to do questions now for a few minutes. Just letting you know, these are some of our resources at Gene House. This is the vulva booklet that I mentioned before. And there are webinars that Tanja has presented at before, which are in our webinar library. And these are some of the resources which you'll have in your notes of the different societies. And the correct title of the one that Tanja is about to become president of is the International Society for Vulvovaginal Disease, which I got mixed up. So thank you very much for your attention tonight. For the for the webinars, you can have a look on our website, and you'll find a whole series of different ones, including 4 on vulval health. So thank you very much. And now we're going to go to questions. A number of questions have come in about the fact that you said that in chronic candidiasis, when you swab, you may not see any candida.
Yes.
And that's because?
That's because in that situation, the amount of inflammatory response that can be present may mean that there is more inflammatory response for fewer organisms. And also, as with that lady with a lot of thickened skin, you simply aren't able to get deep enough with the swab.
So in other words, they're in the cells underneath the surface.
Yes, and yes, exactly.
Or in the keratin.
In between the cells,
keratin.
Especially in the keratin.
Yes, yes. Now, we've got a question here about treating chronic vaginal candida glabrata in obese postmenopausal women. Is this something that the candida might be a normal commensal, or there would have to be risk factors?
I think the reality is that there are still people out there who would say that glabrata never causes symptoms because the overall inflammatory response is so much less when we are looking at glabrata. But if you have looked at things such as the factor of heat, perspiration, irritation, what is being used as a cleanser, what might be exacerbating in form of clothing, and also examining the vulva, regularly, and what you're persistently showing is a growth of glabrata. In that sort of setting, it's reasonable to expect that a 2-week course of the boric acid vaginal pessaries will in fact eradicate that. What we don't know is whether or not it'll keep coming back.
Right. So one of the things that we read about in the literature is that in a vaginal microbiome, you can actually have candida organisms there, which are part of the normal microbiome. So if you do a swab for a discharge and you find candida albicans, but there's no real infection, there's no redness or anything, do you treat them?
I think it depends on the context of what you're looking at them for. If you're looking at the patient and the patient's complaining of itch and a bit of discharge or itch and disruption to sleep and you can find no other pathology, yes. Or if they've got a history of being on lots of antibiotics, yes. The reality is that in that sort of clinical setting, you can take candida albicans almost out of the picture by giving some oral fluconazole and seeing what happens.
Great. Now, there are a number of questions here about pregnancy, and I'm quite interested in that because my daughter's now pregnant. So,
congratulations.
Any advice for pregnant women with recurrent thrush, especially if they're close to delivery?
It's a difficult one, and it's one that it depends on how close they are. It's fortunately does not seem to be as big an issue with premature rupture of membranes, etc., as the group B strep that is found. So having a lot of candida may make mum very distressed. It may in fact transfer to the child who will get it on the surface of the skin and possibly orally. There are times, particularly with a mature fetus, where a dose of 150 milligrams of fluconazole can give a great deal of symptomatic relief and without a lot of issues attached to it.
But you've already said we wouldn't use it in pregnancy.
You wouldn't because of the risk of hepatotoxicity, but a single dose at term or just after when breastfeeding is occurring may well be indicated, but that's something that needs to be individualised for the patient. You shouldn't be using the azole creams. Boric acid can also be teratogenic.
So you'd use Nilstat.
Nystatin is nice and safe.
Okay. And so if somebody's got ongoing chronic thrush in pregnancy, how do you manage those? Do you just keep using the Nilstat?
You do, and you might start off using it every night for 10 days to 16 days and then cut down to every second night, every third night and find out how much you actually need to use it in order for the patient to be asymptomatic. You probably will not be able to achieve a mycological cure in that clinical setting.
Now, I thought there were a number of interesting questions about treating the male partner of a woman. And is it recommended that partners are still treated at the same time?
At this point in time, they're not. And that there have been some studies, and this is where it becomes a difficult issue, because I think it makes sense that if we can find Candida albicans in ejaculate, and that it would make sense to treat the male partners at the same time. But it doesn't seem to be borne out when it's actually looked at in trial situations. I think as usually we say, unless a partner is diabetic or is having symptoms, and the symptoms are usually a couple of days of irritation after coitus, then they should be treated on their own merits. And I've rarely treated a partner, but when I have, it's usually been in the setting that he gets a few symptoms and she's chronically got thrush, and in that setting try and time the therapy so that it is concurrent for both of them and no intercourse and transfer is occurring. But that is not based in good evidence.
And does it matter whether the male has a foreskin or not, or is circumcised?
I can't answer that question.
Okay, fair enough. Now, you talked about hydrosol and not using it.
Not as a primary treatment for candida, no.
Right, okay. So you might use nystatin plus
A steroid. It might be a 1% hydrocortisone, or you might think there's that much inflammation that you need to use a little bit of betamethasone, and either the valerate that's in celestone M, for example, or even something as potent as the betamethasone dipropionate or olifrat or diprazone.
And that's really to reduce the inflammatory.
Yes, and that is not continued long term. That's done and once tissue has resolved.
Now, when women go to the pharmacy, they've got so many different products. They've got a single-day product, they've got a 3-day product, they've got a 5-day or 6-day product. What do you recommend for the acute candidiasis?
For the acute one, and this is a situation where I say many people in our audience, particularly those who see their patients first off, probably have more experience than we do in the vulval clinic, for example, or I do as a dermatologist. But my preference is to use something that is an azole and that would be used for approximately a week, because in that setting, there's generally some tissue inflammation. And again, they are all shown to be effective in that very short period of time when mycological studies are done up to a week, 4 weeks and 6 weeks. I think if there's a lot of inflammation, or if women are just feeling just so itchy and it's been so bad and they're swollen, something that you take for a little bit longer means that you give your tissue more time to settle down, and you then are going to have a greater chance of actually using it comfortably and most effectively before you stop.
So what you're saying is that the actual products that are available on the market are far too short for what you recommend, because 6 days is the longest.
For the women that I see, yes, because the women that I see have already done this trip.
Yeah, but if you're the GP or you're the practice nurse or the nurse practitioner, and somebody comes in for the first time, how many days would you recommend? Still the week?
No, I think in that setting, most clinicians would have their preferred agents that they would use.
So it doesn't matter whether it's a single 3 or 5 or 6.
Yeah, it doesn't in a one solve. Say, for example, they've had a course of antibiotics and they've got thrush. It shouldn't matter, according to the literature that we have, what they did. It should be enough. But they should then make a point of seeing them about a week later and making sure it was enough.
Right. Now, we have many postmenopausal women at Jean Hales, of whom a very high percentage are on estrogen vaginal preparations, and that's going to increase their risk for...
Yes, it will.
For vulvovaginal thrush.
Yes.
So antibiotics, so recurrent urinary infections in the postmenopausal woman, but children and postmenopausal women do not get thrush.
Unless there's something else going on, and I would put it to you that recurrent courses of antibiotics is one of those things.
But if you had, so in somebody who's fit well and not on hormones, not using, is not diabetic, etc., then candida doesn't happen.
It shouldn't happen, no.
It shouldn't happen.
Yeah.
Okay.
It's a biological system. You can't ever say 100%, but no, it should not happen.
It shouldn't happen. Okay. All right. Well, I think that hopefully we have gone through and answered most of your questions. I'd like to thank Tanja very much for participating in this evening's webinar. Thank you. It's a very, very interesting and a very important topic.
And a difficult one.
And a difficult one, yes. Really no clear long-term answers. So I'd like to thank you all for participating in tonight's webinar, and we will let you know when the webinar will be up on the website. Please do fill out your questionnaire on this evening's webinar, and we wish you all a very happy rest of the week and time, and look forward to presenting to you our next webinar. So good night and thank you.
Good night. Thank you.